Hey, I think we're on. Thank you, Karen. It's great to have you here. We're not going to we haven't been making long introductions because all the profiles are in the brochures. So Karen, of course, is the new national coordinator, the chief of the ONC that many of us either love to throw things at or praise or complain about, depending on what day of the week it is and what news has been made and how good we feel about systems that aren't working or how many forms we filled out that day at a doctor's office. So they get a lot of blame, but they're doing a lot of work as well. And that's really what we wanted to basically talk about today is, from a privacy perspective, all the new things, and as a new coordinator, there are a lot of changes that have been started, and of course lots more coming over the coming years. And so what I wanted to do was to first put up this map. It's a little bit hard to see, I think, for you guys in the back, but all this is supposed to show is, how many of you know about thedatamap.org? Okay, so this is not new to most of us here. If you can't see it, just go on, if you're connected up, go to thedatamap.org. And what I wanted to do was to basically get this up on the stage. I work with a lot of, as a contractor, I work with a lot of federal government staff and folks and officials, and we kind of expect a lot from our federal government. We pay a lot of money, it's a big budget, et cetera. But this is what we're trying to talk about. This is what we're trying to solve. And so nobody should feel like this is something that's simple. But at the same time, as I said in my opening remarks this morning, it's not impossible either. So how do we get from dealing with this level of complexity and the need for all of the things that we've talked about all day, which is privacy, and now we have somebody sitting on the stage who can actually make some things happen, hopefully, at the government that will either tell us that this is hopefully just a few weeks away that we can solve all this, or it might be years away. But no, I'm not going to put her that much on the spot. But what I wanted to do was to just let you comment a little bit on, based on what you've now seen in the last few months that you've joined, knowing the complexity because of your own practice in the past. How big is this problem of privacy specifically? Security is a different matter. And what role do you think the government can and should be able to play in making things better?
I was hoping you were going to ask me what my reaction was when I saw it, at which point I was going to say that I seized. But you didn't. And I say that a little tongue-in-cheek because it is really a nice illustration of the complexity, as you say, that we are dealing with in this world where information is increasingly captured about individuals and shared in a variety of ways with consent often, but sometimes as outside of the health space. I think we've all experienced as we're online shopping, things come up to advertise to us that we can't believe that actually that company knew we wanted to buy, but it was because we had looked. Mm-hmm. And so information is everywhere around us, and particularly though when it relates to our health information, this principle of it being private and us having to give consent about how it's shared gets increasingly complex. Mm-hmm. And we at ONC, but more significantly perhaps at HHS, have this as a high priority. The Secretary said it in her remarks yesterday, actually at Datapalooza, that it has been and will be ongoing the top priority for our agency, our department, to see that we are thinking through the right framework for privacy of data, especially as it evolves and becomes increasingly complex and in motion to benefit patients, but for other purposes as well.
Yeah, that's great. And I think that key word of being in motion is what creates all of our problems, especially from Datapalooza this week. So last week we noticed a fairly sized reorg announced, and from 18 offices down to 10. Movement of especially some things that we've seen before is the consumer side moving into the other programs section. Can you talk a little bit about the reorg? So what about the priorities have changed that caused that reorg? And where does interoperability fit into this? Because that's something we care a lot about here.
Mm-hmm. So I just, for those of you who don't know me, this is about my 5th month at ONC. I came from And I was supposed to say this at the outset, at least this is what I wanted to say. I'm a doctor, and unlike Deb, I'm not also an expert in privacy. Please bear with me as I make sure that I say this correctly as much as possible from the legal and policy framework. But I came to this job with a background in clinical medicine, in public health, in academics, teaching, and a snapshot of what the potential is for the social determinants and social services agencies to be able to inform the saving of lives in the event of somebody needing wraparound services, whether that was through hospice or anything else. And so I really was excited about the charge that the Secretary had given us to think about IT as not just IT, health IT, but really as a key driver in improving healthcare and health for everyone in our country. And that to do this, we have to continue the march forward around capturing data in standardized ways. So the electronic health record, certified through a variety of processes, has really advanced dramatically in the last 5 years. So we have reached a tipping point in the country where through stimulus funding and other efforts, there's been this adoption of electronic health records in the hospital and clinical environment that is now driving a lot of important discussion about how we put that data in motion to the benefit of patients, to connect care, to connect outside of that sphere, to see that the resources and support that a person needs is available to them when they need it, data and otherwise. This is a critical part of seeing the promise of HIT come to reality to improve care and health. The rapid growth and advancement of HIT through the ARA funding meant a rapid growth and advancement of ONC. There was a couple of $1 billion of stimulus funding that we had as grant programs, but other contracts and work. We grew a privacy and security shop. We grew a new certification program. We grew a lot of relationships with some 130,000 providers in the community. We have a consumer e-health portfolio and the Blue Button program. And what we have to really think about at this juncture is, of all that growth and all that important work, how do we get as focused as possible in our next chapter so that we are making a really efficient and effective use of the taxpayer's dollar? Doing that in a way that sets a clear roadmap forward for assuring that we are fulfilling the promise of health IT to improve healthcare and health for our country, everyone in the country, but doing that in a way that is as focused as possible on what are on the key priorities. And I want to just stop there for 1 second. Well, let me tell you what we did in the reorg, and then I want to get to the key priorities, if I could do that.
Yep.
So the reorg is really actually a strategic alignment that moves some functions to existing offices. So, for example, the Office of Standards and Technology has always been in place, but we moved certification into that sphere because there's a lot of implementation work and technical work involved in that space. There's some renaming. The Office of the Chief Medical Officer was doing the work of quality and safety, and to the outside world wouldn't be clear that was the portfolio, so changing that name reflects what's actually happening so people in the community know what door to go in if that's the kinds of questions that they have. And then was an opportunity to create some new leadership roles for people, but then also to put together work that was synergistic and more alike. Policy is a great example. As we grew quickly, there's some work in state and public health policy that was happening in some of our other portfolio, like the program shop, that is better aligned with our policy portfolio to make sure that we're taking advantage of all the talent in that space. Wanted to flatten the organization, meaning that provide fewer layers between the very senior leadership, the immediate office, and the leaders of those programs. It's a small enough office that it would enhance communication, and that it would, in an entrepreneurial style, allow for a more matrixed approach to work. We already are a pretty matrixed organization, but this is hopefully a way to enhance our communication. Nothing is perfect in a silo. I wanted to enhance that. I just wanted to say something about priorities since you mentioned it, and Bill Yasnoff is here, who I had a conversation with when I first started the job. Public health background, similarly, and reminded me of the power and importance of community health assessments and improvements and setting shared agendas. And though in ONC we have set interoperability to connect care and information on behalf of patients and consumers as a high priority, I just want to take a minute to make sure that it's clear to folks that we didn't do that in our box at Humphrey. I spent the first few months doing quite a bit of informal environmental scan and formal environmental scan, looking at what kinds of writings, letters, comments we were receiving from our stakeholders of all walks, thinking about questions to ask in conversations both in DC but across the country with individuals and stakeholders about what mattered. And this is a priority that comes up very often, that we have been capturing data that's at rest and in silos, but to really make it powerful, we have to find safe and secure ways for it to move for the benefit of people. And doing that is complex across the board. It takes a set of expectations and agreements around governance of that information at rest and in transit. It takes a set of agreements about the standards and the technology involved, about how we're going to support that financially going forward. What is the right regulatory environment to allow that to happen? What are the safeguards that we put around that data going forward? How will we make sure that the use cases make sense to the clinical world and otherwise, so that it's got a sustainable model going forward? It's the reason I tell you about all the complexity of interoperability, because you all know this, but because as a reminder, as we thought about reshaping ONC to meet the future needs of a differential funding expectation of a different world that's coming, we wanted to also think about how we could be structured so that we could answer some of those big questions in partnership with the private sector. And do that to make sure our teams were as maximally effective and efficient as possible. And we could get into the weeds about how we did some of that work, but it is that interoperability piece, which is an unfortunately very technical term, is so complex. It does require all of that team to be at the table and then some. It requires all of us to have some shared responsibility, thinking through how we're going to get there in a way that meets everyone's needs and expectations. But also it's going to take a lot of work. It's a collective impact approach, and we are just beginning that journey at ONC. We will be shortly releasing a vision paper that will be an invitation to folks to come to the table to talk through how we can get there, working on a clear roadmap for how we can go forward. Some areas will need to lead. We have so much strength in our privacy and security shop under Joy Pritt's leadership. That I see that as a place where we can really help lead. There are other places where I think the business modeling, et cetera, we need states and private sector to help think that through. But we will be working on that with the federal HIT partners. This is one of our congressional responsibilities, is to set the federal HIT strategic plan. They have all already shared. That is a top priority amongst other things. And we will be going out to the community to develop a shared national set of priorities, an agenda that we can all agree on, that will involve our interoperability, but I fully expect it will have privacy and security of data at the top, because as you know, it's that privacy and security is not just about interoperability, but about big data and individual data and this growing mass of data that may help inform people's health.
So what are your thoughts on the general fear? So one, I'm a big proponent, and I will cheerlead anytime anybody's doing anything around interoperability. One of the worries around interoperability is what happens with privacy when like Datapalooza earlier this week was all about pushing data out, making sure it's open and transparent, et cetera, which is all great. And of course, we want to push that because better data and more transparent data hopefully means better care, lower cost. Where do you think the biggest dangers are from your perspective, either from public health or other areas around privacy, and what should patients be worried about as we promote more and more interoperability? Where can they help out? And talk to us in this realm of the ownership side, right? Because there's a question when we look at data transparency. If I'm an institution and I collected data about you as the institution, that's transactional data for me. Patient comes along and says, wait, that's my data. Who's going to set that tone to say, does all of this data really belong to the patient, even though it's part of the institution? Or is there some institutional data that they don't have to share with the patient? And I know you don't have all the answers to this today. What is that framework that you think that you've set up? And some of this may fall to Joy's office directly, and she's speaking here tomorrow, so hopefully we can ask her some questions as well. Where do you think that framework is going to help determine some of those answers?
So at the department, generally, because the big data is about data beyond ONC's realm, but at the department, I said it at the outset and I'll say it again, the privacy and security of the data is a top priority, and Joy can get into a lot more of the details about some of the strategies we have underway, not only in HHS, but with the White House and others. I would share with you that HIPAA is the foundational framework for what we do, and within that, this importance of patients having access to their data and a related issue of consent about how their data is used. A nod to our privacy and security team, for example, that they have been working in two streams of work, as an example, to simplify and clarify the consenting of data use. This is for providers and patients and caregivers. Of utmost importance is that we have clear consent around how our own data is used, whether that's for our individual care or at a grander level, that those consents are clear and concise and informational and transparent and available to be seen, and language and culturally appropriate. This is a complex but something incredibly important that we have to keep working on. And then by the same token, that providers, doctors, hospitals, other providers understand the importance of data security. Some work that we have done to begin to simplify the training around data, so that there's some, for example, our security or risk assessment tool, which is out for comment. We're looking for some feedback about how to make that better, simpler, more available. As a doctor, when I saw that tool, I was really excited, because it was in all the trainings that I have had around HIPAA and privacy and security in my 20-year career. It was the most straightforward and just enough, get your attention about what can be really done. So I think this is a shared responsibility, is where I'm going, is that the department has responsibility, the White House is weighing in, we have partners in the federal government, but the providers, the patients, and the private sector have to make sure that we're really clear with folks that they have a right to consent to how their data is used, and make that available in such a way that it is not confusing, and by the way, that they can change their mind. Right,
yeah, makes sense. And by the way, we're going to open this up for questions, so have your questions starting to be thought about. So the two things that she mentioned, which are very important, is the SRT. How many of you have heard of the security risk assessment tool, SRT? That's good. So you should check that out. It is a downloadable tool that helps you figure out the checklist and what should be done. So setting that baseline, we should not consider that the full security checklist, but it's definitely a great start. And the other thing is on the e-consent. How far do you think we are, just generally speaking, from ONC's publishing of the e-consent requirement? Is it still pretty far away? Because I really like the general direction of moving e-consent into an executable consent, not just a sheet of paper that you hope that we're going to go into. So there is some work going on there. If you have any information on that, I'd love to hear.
I don't have any late breaking news, but I bet you Joy can tell you tomorrow. What I would share with you is this is back to setting a set of shared national priorities and a shared national approach. In some of these areas, for example, ONC under R really pushed and encouraged our grantees to put patient privacy and consent at the front, the opt-in, opt-out options, and really begged the question in actually a really important way. I had been a grantee in a prior life, and I remember those conversations, and it went all the way to the governor's office about what were the privacy and security issues and expectations in our community. I think also you're seeing a lot of conversation happening in our policy committee, and some pilots that we're doing around the nuances of consent, about the patient's opportunity to segment their data and decide who sees what, when, and how. That is, I think, an area that's really ripe for conversation and for technological and policy conversation, and it sort of relates back to what you're saying of who can see what and for what purpose, but sometimes it's the data around, for example, substance abuse treatment that would have more implications, but we are already trying to work through some of the questions and potentially some solutions, but I do think that there's far to go in that segmentation space.
Mm-hmm. And do you think especially from a consent perspective, given how complex it is, do you feel that, that this is an area where you'll just set the floor from an e-consent point of view and say, okay, this is the basic that we have to do, and then there will be a lot more innovation that the industry can do on top of that? Or do you feel like is it too early to know? I mean, I would love to hear about how far you guys think you're going to go with consent, because it's an area that I think is ripe for innovation, and there's enough people that care about it that we can actually see new startups begin around just that one industry. Just like 5 years ago, you saw some explosion around health IT in general. Do you feel that, have you heard from constituents that consent is that big a deal where more innovation can come around it? Or are you looking at it just like sort of, it's just a necessary thing, we have to do e-consent if we're going to get any privacy in the future?
You know, it doesn't come to me, but that's probably because Joy's fielding all those things before they come to me. The kinds of innovations that I'm really approached more about have to do with the rolling up for big data, and the desire for innovators to have access to information that they can do machine computing around and try to answer big population level questions or look at value-based purchasing. As you saw at Datapalooza, though, also a lot of interest on using people's individual data to help them self-manage, or bigger or data to help make choices in their self-management. So maybe tomorrow she can talk to you more about the innovators in that space.
Sure, and well, let's so in that area that you know pretty well, then, what do you think has ONC done well to enable the current innovators, and what would you do in the next couple of years to help improve that? Because as we know, without the innovators piling on more and more solutions, things aren't going to go as fast as we want. But then you also have to keep them in line with respect to data security. So, data privacy in general. So, what would you do? Are you guys going to do anything differently, or just more of what you've done in the past?
I hope that you're seeing some signaling from ONC that we are moving in a direction to do things differently. Some of this is predicated on 10 years of reflection, 10 years of service to the country, 10 years of learning. Some of it's predicated on the changing marketplace where technology is evolving, and there are maybe new technologies such as FHIR, new pilots exposing APIs to allow for interfaces and new innovative apps and other user interfaces that are changing the way we're interacting with data. The marketplace is changing because payers, both public and private, are paying for care differently and driving the need for a better understanding of quality and the effectiveness of care. I have often said, and I'll say again today, wherever this wave has come from, I'm excited about it, but the market's also changing because consumers know that there is data available that, if used appropriately, can help them be better self-managers, help them better self-manage those in their family for whom they're caregivers, and also potentially help, for example, advance cure to disease. So network sites where people are sharing their own health information as part of bigger online communities to help really drive new novel advances. It's redundant, novel advances in disease. And I'm thinking about, for example, Parkinson's or ALS or cystic fibrosis. We're all familiar with some of these opportunities. So patients are, and consumers are knocking at the door, wanting to be in. The innovators can help create those doors. So it is an explosion, and that causes us to pause and look at how we can structure ourselves in such a way that we do create a platform that is stable, strong, secure, protects people. This is our principal responsibility, and accountability is to everyone in this country. One that is raising the floor for everyone to bring folks along, so there is not a digital divide, doing everything we can to make sure rural or low income or irrespective of payer source or type of provider, that everyone has the chance to be healthy with their chronic disease or just healthy, period. Creating that in such a way that we're working with the private sector on focusing roadmaps, standards, governance, bringing everybody to the table to have some clearer picture of where we're going. I've been quoted already, so I'll say it again. It's sort of been a little adolescent phase for IT where we've been experimenting a lot. We had the opportunity to do that because it was new. it's time for us to level out some of this playing field so that there can be new innovation on top. Otherwise, I think we can't get ahead of some of the key issues, and I'll put privacy and security back on the page, on the slate. And so let me just say this too, in case I don't really get a chance, which is all this data comes with responsibility. I've mentioned 1,000 times, and because it's at the privacy conference, there are expectations around privacy and security. We are there to work on that. That is a top priority for us and others. It also comes with the responsibility to think about assuring that we're educating patients and caregivers about their rights and opportunities to consent in or out of data and change their mind, and that we are working on ways that they can share data in such a way that it makes sense to save their life when it matters, but also protect their privacy. It's also incumbent upon us to be thoughtful about, I'm saying us, like not ONC, so the world, to use the data in ways that are going to advance health. And why do I say that? Proving known things or just creating new things is great, but it would be so valuable if we used this information, whether at the individual or larger level, to advance care and lower waste and redundancy in the systems, to avoid folks from having to get stuck by needles again and again, or to have go through the CAT scanner again and again, or fill out the forms again and again, all the way to thinking through how we can extend life expectancy and quality of life, improve quality of life for everybody. Those are the kinds of questions I want us to ask. Those are the things that we can do as a country, and as long as we're respectful of the information and put the patient right front and center and think about them as someone we want to advance and help, then the innovators, I think, are going to be moving in the right direction.
So one class of innovators, which many of us in this room either praise at sometimes or yell at other times, is the class of data brokers or data hubs, or the people that are taking data from one group to another. And in the absence of true e-consent or executable consent, as we might say it, what do you think the government's role is in regulating those kind of brokers who, if we leave things unfettered and unleashed, the data will go in and the outcomes will actually be good, because more data in many cases means better care. But in many cases it's much more dangerous, because more data means more people lose their jobs, they don't get to see the doctors that they want to do, more people get fired from jobs, et cetera. What do you think is the role of the government just in that one new area of data brokers, if any?
You know, more data isn't always better. I spent a part of my career working on research of showing that a single question that asks patients in general, how would you rate your health, excellent, very good, good, fair, or poor, is as powerful a predictor of someone's subsequent need for hospitalization, medications, mortality, as really complex risk adjustment and prediction tools. Complex as the ones that we use in the Medicare program. A little event called Katrina changed my career trajectory, and I stopped doing the work, but others have done it. And I share that with you because that one question comes out of something, a longer tool most commonly known to folks is the short form 36. It used to be many more questions, where you'd ask somebody 36 questions and predict their outcomes, and then they sort of got it down to 12, and then to 8, and then to 6, and I was working on the 1. I'm a lumper, not a splitter, and in the survey world, that's a big deal, but it also is relevant to kind of what you're asking, and I think this whole issue about data and just grabbing it for purposes of 'cause it's there. It's back to this, let's be thoughtful about what it is we want to know, and let's also remember that sometimes even just asking the patient what it is that they know and feel and project about their health is as powerful as all the other things that we can collect and accumulate. So I want to make sure we leave space for that. I would say to your question, which I'm going to really talk more about the broader data again, and that is with HIPAA as the foundation, but with the world evolving, I think there are new questions arising that we need to be thoughtful about what's the right legal and protection framework. The White House, as you I'm sure know, put out a white paper on privacy and security of data, big data in particular, and we had the chance to participate in some of those conversations. I think there's going to be some ongoing work in that area to try to get at what is the scope of the challenges we have going forward. How do we ultimately protect people and make sure that the use of the data is from their consent, and that they're not discriminated against based upon it. You touched on that, and because this is something people care a lot about. The majority of folks, 3/4, want to share their data if it's going to help others and advance their care, but they're most worried about being discriminated against. And that's from some survey work we've done and some work that we're going to continue to biopsy and look at. So it's on our radar. I think everyone has a shared responsibility in that, though.
Right, but you don't feel like, so in the case of FDA being able to regulate device manufacturers, or ONC being able to regulate, at least from the certified perspective for EHRs, kind of data brokers are somewhere in the middle or on the side. It's not something that you guys have talked about much internally to look in the particular direction, it looks like.
From a regulatory standpoint, some of the stuff you're talking about would be in our, we're in a comment period about our FIDASIA report, so it's a place to look, but it's not, they might correct me, but I think that's all part of a broader future framework. Was that right, Joy? Yeah, it's not really in the FIDASIA piece.
Yeah, no problem.
Because that's more about the safety side.
Right. Now, you talked about the shared responsibility. In this reorganization, was there any change in the importance of Blue Button, the importance of how much access and what kind of access patients should have to their data and that portability, or did it get strengthened? Just any comments on how much control we have? Is it more or less after the reorg and what you're looking at over the next couple of years?
The Blue Button program, which is part of Consumer eHealth, is where it has been in the program's office. It's actually, we've reduced a couple of layers between that office and the national coordinator. IGEA is an advisor to the national coordinator and has a hand in looking at the work that we do and always will. It's that program is got a life of its own, as I learned really quickly when I got here, and as you see from all the buttons people wear, but all the innovators in the space, the fact that the VAs had an increasingly successful opportunity with it for their veterans and others. It's a set of standards. It's a culture, a philosophy about people's opportunity to have access to their information, and it's unchanged in the commitment there. What I would kind of loop back to, and I would hope, I think IGEA agrees with this. I hate to speak for people, but that the Blue Button is such a great first step towards opening up the window, the door, the whatever, the portal, to seeing what information we have about patients in the system, whatever that might be, whether it's lab data or pharmacy data or claims data, where I would want to be as a patient and where I would want my patients to be as a doctor and as a policymaker. What I'd love to see is that there's this opportunity for bidirectional sharing, so that it's not just that we let patients see what we think about them, but they have a chance to tell us quantitatively and otherwise about their own health, and we can incorporate that into the record as well. So the step beyond as we evolve is bidirectional as well.
Okay, so
but it's additive.
No, that's great. So in the late 90s, the government took a stake in the ground with HIPAA and said this is what they're going to do with confidentiality, and it sort of morphed into trying to become a lot about privacy controls and other things. You mentioned HIPAA a few times. Do you feel HIPAA is a good place for us to now say that it is well grounded enough, even post omnibus? I'm assuming everything from last October withstanding is. Do you feel like we're in the right place to now have what we need for the innovators to bounce off of that? Or do you think there's more that the government needs to do, and nothing happens fast in the government, so it's okay, but more that needs to be done in order for that innovation that we want?
It's the first time anyone's ever said that to me, but that's okay. Nothing happens fast in the government, but that's okay. I'm just teasing. This crowd's very tense. I don't know. I'm going to have to get up and tap dance or something to kind of get y'all loosened
They're
up.
hanging on every word you're saying.
Especially Joy.
Yes.
Let's see. I'm gonna give you my doctor response. HIPAA's the foundation. There is additional protections in the high tech. I think the privacy, the big data and privacy and security report that came out that John Podesta did indicated that we may need to look further, and obviously we would be in concert with that. So there are layers, but I do believe that it's time that we look beyond. I mean, not Karen, but this is sort of what the experts are saying within HHS and in the White House, that there's a foundation. It's been expanded upon, but as this field rapidly evolves, we need to think about what additional protections might need to be in place.
Right, that's great. So questions, anybody have something coming up? Please do take your positions at the mic. So just your name and affiliation.
Scott Mays, Health Leaders. I was wondering if, you know what, I can't remember my question. I'm going to wait.
Okay.
Adrian's got 40 questions, that's okay.
You could ask me something simple like my age.
With respect to both interoperability and innovation, we're now, I think, at a place where we have three competing governance models. We have private exchanges, we have state health information exchanges, and we have patient-directed exchange, Blue Book Plus being part of that. Do you have, how do you, so going from there, I believe about 3 weeks ago, a high clinical official in the Veterans Administration said the future, and Deborah knows his name, said the future is health records will tend to go with the patient. And I think you've said something similar in a public forum. Do you see interoperability and innovation shifting the balance from the very institutional focus that we've had towards either the physician or the patient-focused exchange?
Generally, yes. The foundation that we have of health data in this country right now is predominantly in electronic health records. There are, in some cases, decades of accumulation of information that has informed health systems in a variety of ways. Some started as lab systems, some as business systems. Layer on the opportunity to add some other supports around inventory, quality, safety, right, clinical care. And so there's a rich set of data there, and it continues to evolve and grow, and adoption hasn't ceased. So that is one layer of information. All of that may or may not be necessary for you as a patient to carry with you as you go. So the exact dose, I'm going to use the exact dosing of Tylenol at 3 in the morning when you were hospitalized. That may matter more perhaps to that health system than longer term to you, as long as it's available and hosted there if you need it. So you can start to create in your mind the opportunity that there may be some legacy system data. Some pieces of it may be more relevant for your ongoing self-management and or portability as you go from system to system. We're also seeing the evolution of new kinds of data capture. Quantified self is a great example. Patients putting their own information in the cloud, and some cloud-based electronic health records that are evolving. And that is importantly opening the mind to the fact that data doesn't have to live in electronic health records, but actually is better following folks. The Jason report, which came out last month, and no, 2 months ago now in April. It is interesting in many ways. It was started last year before I came. It was commissioned by AHRQ and ONC, and Robert Wood Johnson had a hand in it, the Robert Wood Johnson Foundation. It took some scientists who are not really technical people, asked them to solve a problem. They came up with a framework, a conceptual model that goes a little deeper than a conceptual model, but to say something along the lines of how could you evolve from a system where you had electronic health records that were the principal holder of data about people's health, and move to something that had a platform on top or with more on and off ramps that will allow for the kind of innovation and future that you're getting to, which is a health data bank or a personal record that maybe is controlled by somebody in a different way, can create integrated longitudinal record. Not all that exists yet, but back to his question about who are we, what is our responsibility, I think, is to help shape that conversation as the national coordinator and to think about what does that platform look like that becomes much more patient-centric and less centric about an EHR, because the future is towards health is going to require that we have other ways of data to move. Thank you.
I remember my question.
Okay.
Data
I'll
segmentation
try
for
to
privacy. This might be a Joy Pritz question, but I'll ask you anyway. Do you feel that you have the charter to go forward with that based on previous policy decisions by the administration and others, or do you feel that there's now some talk that maybe you need more legislation to keep doing some of the things you're doing? And I just wondered, in relation to that topic, the privacy topic, do you feel like you have a mandate to go forward on that? Or is that a Joy question?
Let me answer generally, and then she can answer. I would, so the ONC as created by executive order, but then created as an agency in 2009 in the HITECH Act and given a set of authorities that, for example, call for us to develop a federal HIT strategic plan, to have an Office of the Chief Privacy Officer that informs not only ONC but HHS, to establish governance for a national health information exchange, and those are available publicly. As we set the future agenda, we, in the federal government, in our federal HIT strategic planning process, and then in partnership with the private sector in the months that follow, we're going to have a much better sense of what is the right balance of regulation and coordination and responsibility, and so we look forward to the conversation. Do you want to?
Yeah, because nobody will hear you online.
So specifically with respect to data segmentation, the HITECH Act itself calls it out as an area where we are directed to explore. So I think it's pretty clear that we have the authority to work on that issue, and we have done a lot of work on that issue, as you know. It's also, I think, really indicative of how committed we are to this, to take a look at the Secretary's Strategic Initiative, which is available online. And what that is it's where the HHS sets out what its initiatives are, the things that it's going to work on in the upcoming years. And I think it's a 4 or 5 year period. For the first time ever, privacy and security is called out as a distinct initiative. And among those initiatives is work on facilitating the exchange of health information and developing or looking at technology that facilitates that.
Thank you.
Thanks, Joy.
I'm Peter Robichaux with Category 3 Partners. My primary work is helping covered entities secure EMRs. And what I've seen in the wake of the HITECH Act is once you incentivize EMR implementation, you let the genie out of the bottle. People implement EMRs and everyone wants access to the data, whether or not it's been secured properly or not. I'm particularly interested in the National Healthcare Security Strategy, which HHS has put out. It's in a comment period. In that, one of the goals is the incentivization of data collection and dissemination. Obviously, privacy is part of that, but what do you do to avoid what happened with the HITECH Act, where you incentivize without giving people the tools to properly secure the data that you've incentivized?
So you are, I think, speaking back to what Joy mentioned, which is that within HHS, there are sort of two priorities. There are a host of priorities, but there is a clear priority in black and white that that privacy and security of data and it has primacy, and that patients have the right to access and to have consent about who uses that data. It is happening at the same time as this other movement you're describing, which is this desire for open data and where the HHS is publishing and all of the federal government information online and in ways that are appropriate. And there's a drive by innovators, as he was describing, to make good use of that data. It is, there is not going to be a conversation and a strategy around that without really thoughtful input from the team, not only in ONC, but OCR and others. because that's the secretary, and I'm certain that Sylvia Burwell will be similar, although she hasn't told me directly. But it is a priority that we are really being careful with the privacy and security issues. It is. I think no matter where you create data, there's going to be interest because it is now its own economy, and it is something that's very futuristic and sexy, and people see as a way to find solutions to all that ails us. But I said it before, and I'll just underscore it again, it comes with responsibility. And some of that is around privacy and security, but there are a series of other ones, and we'll certainly be paying attention to that as we go forward. Thank you. Last question?
We'll go on one side here.
Oh, this guy was here longer.
Oh, you were here longer?
If I'm really super quick, I might get both of them in.
You kind of touched on the importance of mobile technology moving forwards and how it's changing. More explicitly, do you think mobile technology might be involved in meaningful use going forwards? Because it's been pretty absent, would you say, and very EHR computer-based?
It prompts me to want to ask you what you mean by mobile technology, because it's a ill-defined, fuzzy term.
So just incorporating like those apps you were talking about, like that track personal health records or quantified self. I mean, generally that kind, or also, I mean, yeah, it is very broad, but.
I think that field is at the leading edge, and we are, as part of our internal processes for our strategic planning, but then as part of this national conversation, I think you're seeing this conversation show up in other places in the country, also in accrediting bodies. What is the definition of mHealth, and not just from mobile apps, but from wearables and ingestibles and whatever else ables. This is, it's a fast-moving area, so we first have to get some definition around it. I think we have to recognize that a lot of this right now is patient-generated data, that they then have a lot of choice about who they share it with and where it goes. By and large, like my Nike Fuel Band, it goes to my phone, but I don't necessarily have to share everything with everyone else. But that's going to evolve pretty quickly. So we're absolutely looking at it. In fact, in a structured way, it's going to be a part of our conversations with our FACA. It'll be part of our federal HIT strategic plan. Whether and how it's a part of meaningful use 3, I can't say right now.
Okay, thanks.
Thanks.
All right, last question.
Okay. I think it'll be an easy question. But first, my name is Brian Baum. I'm at VitaTracker, founder of VitaTracker. And I guess as an entrepreneur in this space, I would say your comments have been very encouraging and reassuring. Coming to the conference here today, one concern I had was, since I think we're finally getting to a point in the industry where we really are moving to consumer-centric healthcare, and the privacy issue has the potential to derail some of that. But I think what I'm hearing here today is that there's a very high degree of interest in sharing data with the appropriate protections and with consumer consent. And that's what my company is really focused on, is managing that consent. What we've been looking at is how do we coordinate across multiple different sectors, because the implications are different from the pharmaceutical industry to the provider, payers, and all. And our view has been, if we come up with a working solution, then that's more easily adopted. Do you have any suggestions for who or where we may collaborate with your office to advance some of the things that we're doing?
Yeah, we don't encourage collaboration.
That's going to be
someone's
the
going to tweet
soundbite.
that. DeSalvo said we don't encourage collaboration. Go ahead. Yes, we have a few ways, and as a vendor probably varies a bit, but for example, we have work groups in our FACAs. One we just formed, we restructured our FACAs and the work groups and created a space in there to talk about mobile health. We still have privacy security space for conversation. I think today is the day to put in your information if you want to participate in the work group. But if you go online and do it, you just need to kind of fill out some basic information, throw your CV and your bio up there, and tell us if you think it's your top 5 or something areas of work. It's on our website. It'll just take a little bit of time. It'd be great to do, and we'll see how many people were able to get in by the deadline, and we'll make a decision about whether we want to fold in more. And I was being a little facetious about the collaboration, but we're not going to do this in isolation. We can't. We shouldn't. We work for the country. And so we should be doing this in partnership with others, and we should be having as many voices, as many varied voices, and a very strong consumer voice involved in all the decisions that we make.
When's the deadline to sign up?
I think it was today.
5 or p.m. or midnight?
I don't think it's like grants.gov where the thing disintegrates, but I couldn't tell you for sure. I'm sorry. But if you, who can help me? Nora, can you, we don't happen to know the website, the date, the time?
I was just looking, sorry, and then I was like, oh my God, she's talking to me.
Look, everybody's on there. Everyone's thumbing. I'm going to go on.
So while we're finding that out, just from a concluding remarks point of view, what are the kinds of things that you think a privacy-focused community like ours could do to help ONC make absolutely sure that the things we care about get promoted as far as thinking is concerned, et cetera, in this new reorg model? Because I think there was a good sense of how it occurred, especially with the FACAs and everything else. I think you guys have done a pretty good job there. What do you wish you had from the community that that you think maybe the community is not providing as quickly as they could or as much as they could? Or are they giving everything that you need and the government is just taking its sweet time?
Before you said that was okay.
No, it's okay.
Love letters are always nice, especially if they're full of love. And so here's what I would say. I think that the health IT community is active, relatively organized. Much of it is at the leading edge of innovation. I think that what I hope you hear from me consistently, and what would be helpful to keep hearing from everyone, is that we're doing this for the people in this country, and we work beyond with the UK and other countries, but this is about the people of this country, which means that we have to put their needs and expectations first. It's about seeing that we have a healthy, vital community that has great quality of life, and IT is an enabler of that. So we must always put them at the center of our decision making and our policy making and thinking. So help us keep that straight. And I guess probably the other thing I would say is it's very easy in government to get very focused on what's right in front of you. It's probably easy in any job that anyone has, I guess. And if you don't stop and look up, you'll miss the forest, much less the mountains beyond. So the way you all help us is to help us see what's coming that we might not be seeing. What are our blind spots? How can we make sure that we are taking into account everything that matters? So we really do appreciate the feedback in formal and informal ways, and just please keep that up.
Okay, very good. Deb, anything that you wanted to ask?
No, we're really glad that you came.
Oh, it's Friday, June 6th. You got all the time in the world. No, really, it's really easy to do, actually, because I was worried about it and I went on and checked it out today. It's not that hard.
Right.
Have you tried downloading your health record from the blue button yet?
Actually, I did.
From how many providers?
So I don't have anyone who has Medicare and didn't have any other access to it at the time, so I haven't completed it yet. Grandmother, started with grandmother. What's that?
I get 3 or 4 different formats of my blue button record. And when I moved to California, my new doctors are going to know how to integrate these 4 different records. You're back to this thing about how this field is just starting to evolve. It's a fabulous first start for people who can follow through, get the technology, the thousands and thousands of people who it's worked for, et cetera. Are we finished? No. We have so much more work we're all going to do together to make it more seamless, more convenient, more meaningful. And so I agree with you. We have more work to do, but that is such a powerful tool for patients, for empowerment, that we just got to keep driving forward.
All right, very good. Let's give her a round of applause. Thank you very much.
Appreciate it.
So we're just going to take this off.
All right, y'all have a great conference. Thanks. Thank you. Well, this was a wonderful day. Thanks to all of the speakers and all of the audience and participants, the active question askers. Thank you very much. It's really wonderful, Karen, to hear that privacy and security is at the top of the Secretary's agenda and yours. We're really thrilled to hear that, and we'll be at your side to help you in any way that we can. And we would love to invite you to come to our party, which everyone has to get up and run because we're going to start in 10 minutes down at the Hyatt on Capitol Hill, and we're going to have our celebration of privacy. And it's going to be a wonderful chance to hear more about Peter Shar and LaTanya Sweeney, who are two Louis D. Brandeis Privacy Awardees this evening. And everyone will have the honor of hearing from Louis D. Brandeis's grandson, Frank Gilbert, who's been joining us this afternoon. You can wave, and he's going to tell us a few wonderful things about his grandfather, we hope. So please come join us, and thank you for today. We'll see you tomorrow morning at
8.
8? No, that's when breakfast is.
Yes, that's when breakfast.
Breakfast starts because we want to lure you over because it's so hard to start in the morning, right? But I think it's 8:30 again.
That's right. That's right. 8:30.
Okay.
9 o'clock as the day starts.
Okay. Thank you all. Thank you very much.